Hello everyone, this is diabetes mellitus. It will be the part 1 of diabetes mellitus, and this is just for my private notes, but if anyone is watching, I'll be grateful. So, what are the clinical symptoms of diabetes mellitus? So, the symptoms are polyuria, polydipsia, polyphagia, and weight loss. So, what is polyuria? Polyuria means more than 3 liters per day of urine or more than 40 ml per kg. Polydipsia is excessive drinking of water, which is more than 6 liter per day intake of water. Polyphagia, it is eating a lot, but it is not a classical symptom of diabetes mellitus. So the classical symptoms are polyuria, polydipsia, and weight loss. Polyphagia is not a classical symptom, and weight loss can be seen in patient due to the muscle wasting seen in type 2 diabetes mellitus patient, but there will be increase in body fat because the patients also have polyphagia, so they are eating, so there is increase in body fat but decrease in muscle mass. So there is muscle wasting but increase in body fat. So that is why when you look at type 2 diabetes mellitus patient in the western countries, they will be obese because they have muscle wasting but their body fats are increasing. So how do you diagnose diabetes in asymptomatic patients? So for diagnosis, the random blood sugar should be more than 200 milligram percent. The fasting blood sugar should be more than 126 milligram percent, and the postprandial 2-hour value should also be more than 200 milligram percent. The best is the HbA1c, the best test, and its value should be more than or equal to 6.5%. HbA1c is also known as glycosylated hemoglobin. So normally the HbA1c value is 5.6%, and pre-diabetic range or impaired glucose tolerance is between 5.7% to 6.4%. HbA1c is also known is a retrospective test, and it will average out the blood glucose of the last 8 to 12 weeks or the last 3 months. HbA1c represents the average blood sugar value, and if you want to get the blood sugar value in milligram per deciliter, you should multiply it by like 23 to 25, but still that value will not be the exact value. And if the HbA1c value is less than 8% in a patient, you should multiply it by 21 to get the average blood sugar of the last 3 months in milligrams per deciliter. HbA1c is also the best test because it does not get affected by any recent events. So, like any recent food intake, any exercise, or also fasting. These three, they do not affect the results of HbA1c value. So that is why it is considered it. These three things are considered that because of these three things, HbA1c is considered the best test because it cannot be affected easily. So, investigation of choice in diabetes mellitus is HbA1c. The most specific test is also HbA1c, and the most best test to check the severity is also HbA1c, and also the best test to assess the long term control of diabetes mellitus is also HbA1c. But if you want to know the best test to assess the short-term control of diabetes mellitus, it is serum fructosamine, which is also a retrospective test like HbA1c, but it takes the average blood sugar of the last 2 to 3 weeks instead of 8 to 12 weeks seen in HbA1c. So let's talk about bronze diabetes. So bronze diabetes is like when the liver is damaged and it leads to cirrhosis. There is bronzing of the skin, And there is also damage to the pancreas that leads to development of type 1 of diabetes mellitus. So there's damage to the pancreas, that means there's beta cell destruction, and which it will lead to type 1 diabetes mellitus. In, for example, in a thalassemia patient, if the adult hemoglobin level falls because of low production of hemoglobin in the patient, and the thalassemic patient is already transfusion dependent. So in thalassemic patient we can see bronze diabetes. What is the best marker for control of bronze diabetes? It is also serum fructosamine, or known as glycated albumin. Non-enzymatic glycosylation of serum proteins will lead to uh, serum lead to development of fructosamine, and serum fructosamine will check the levels of those in the blood. So let's see what are the values according to the ADA guidelines. So for normal values according to the American Diabetic Association guidelines is FBS should be less than 100 milligram percent, but an impaired glucose tolerance or pre-diabetic person, the value will be 100 to 125 milligram percent, and in diabetes mellitus the value will be more than 126 milligram percent. If for fasting blood sugar, the fasting should be at least of 8 to 10 hours before the value is taken. And if we give patient a 75 gram glucose and we take the postprandial glucose to our value, the value of a normal individual should be less than 140 milligram percent. But in pre-diabetes or impaired glucose tolerance, the value will be 140 to 199 between those values, and in diabetes mellitus the value will be more than or equal to 200 milligram percent. So what are the complications of diabetes mellitus? So for the first complication we'll talk about is microvascular complication. So microvascular complication can be diabetic retinopathy, diabetic neuropathy, or diabetic nephropathy. I'm sorry. Diabetic retinopathy, in this the blindness risk will increase 25 times higher than the normal population without diabetes. Diabetic neuropathy, which is the most common microvascular complication, which can lead to silent myocardial infarction. And diabetic nephropathy, it is the most common cause of chronic kidney disease or allogenic kidney transplant, and for this we'll do hemodialysis because the patient is in CKD, so we'll do hemodialysis. And we can prevent microvascular complications by strict control of HbA1c, and it should be kept below 7% with insulin management. Uh, Macrovascular complication is the other complication which can be seen in diabetes mellitus patients. There should be strict blood pressure control, and there should be strict blood pressure control to prevent these macrovascular complications. There can be in microvascular complications there can be peripheral artery diseases, which can lead to 100-time increase in incidence of development of digital gangrene, or like gangrene in the digital of in the fingers of the foot compared to the normal population. And they can also or and there can also be coronary artery disease, which means there can be an increased incidence of MI, Prinzmetal angina, unstable angina, and coronary artery disease, and its incidence will be increased by up to 5 times compared to the normal population. So what is good sugar control? Good sugar control HbA1c of less than 7%, which is needed to keep microvascular complications in check. And poor sugar control is when HbA1c is more than 7%. So 50% of diabetics who are having HbA1c of more than 7% will develop diabetic neuropathy, which is the most common microvascular complication. If the value of the diabetic patient is more than 10%, then insulin management will be always be the first treatment of choice for the patient. So what is the type of diabetes mellitus? So first let's see how diabetes mellitus works. So if sugar is less than 70 milligram percent, our body will stop insulin productions. And there are some hormones like glucagon, cortisol, growth hormone, and catecholamine which will increase, so they will lead to an increase in glucose in our blood. And in yellow here I have just marked in which diseases the level of these hormones also increase. So glucagon also increases in glucagonoma, cortisol also increases in Cushing syndrome, growth hormone levels increase in acromegaly, and catecholamine levels increase in pheochromocytoma. So these four hormones, they are the endocrinal hormones or endocrines that are released, that are reasons of impaired glucose tolerance except in diabetes mellitus. So in insulin, there are 51 amino acids and it is a polypeptide chain. So it has two chains, A chain and B chain. So A chain has 21 amino acids and B chain has 30 amino acids. So let's go to types of diabetes mellitus. So type 1 diabetes mellitus is due to destruction of beta cells of pancreas that leads to insulinopenia, and more than 80% beta cell destruction leads to the appearance of clinical features of diabetes mellitus. So before the clinical features appears, it is called the honeymoon phase. uh, and age is never a cutoff for type 1 diabetes mellitus. In type 1 diabetes mellitus, there can be autoimmune destruction, that is HLA, human leukocyte antigen, DQ2, DR3. Genetic makeup of the person leads to him making antibodies against his own beta cells, and there can be fulminant diabetes, which can be due to an viral insult like from Coxsackie, mumps, or rubella virus. So radioimmunoassay or RIA, fasting insulin, if it shows is done, and if it shows insulin is less, it will be type 1 diabetes mellitus. But if insulin value is increased initially on RIA, it will be type 2 diabetes mellitus. Uh, then the third type is bronze diabetes. So in bronze diabetes, there is excess of iron which destroys the liver, leading to cirrhosis. And because of this, there is bronzing of the skin, which means there is just increased melanin on the skin. So there is bronzing of the skin. The beta cell of pancreas are destroyed, so there is type 1 diabetes mellitus development, so there is insulinopenia. And there is also diabetic ketoacidosis, which is mainly caused due to severe insulinopenia due to the destruction of beta cells in the pancreas. And investigation of choice for bronze diabetes is plasma beta hydroxybutyrate. It will check it will check the value of blood ketones, but there are also other tests which also check the value of blood ketones like acetone, acetoacetate, and beta hydroxybutyrate. These three are the ketones that will be in the blood, and beta hydroxybutyrate will check the value of the ketone beta hydroxybutyrate. The treatment for bronze diabetes, first line is there will be a normal saline drip should be given, which is hydration, and the treatment of choice will always be insulin, regular insulin given by the subcutaneous route. Insulinopenia is Insulinopenia. So suppose a patient is suffering from pneumonia and the energy requirement of the body increases to fight off the infection. So the body's muscles, they cannot utilize the sugar as it won't enter due to insulin deficiency. So insulin also helps in the absorption of glucose in the body. So there will be subcutaneous fat oxidation, which is used to produce ketones, which will help in increasing the sugar value. And these generation of ketone, like production or generation of ketone, which is used for energy production, will lead to diabetic ketoacidosis, because as ketones are acidic in nature, they will lead to damage in the blood brain barrier, and it can lead to cerebral edema, and that is why cerebral edema is the cause of death in diabetic ketoacidosis. uh, in acidosis there is potassium efflux, so there is increase in the amount of potassium in the blood. Ringer lactate is a potassium rich fluid, and as there is increased potassium in the blood, it can lead to diastolic arrest in diabetic ketoacidosis. So what is the long term management of type 1 diabetes mellitus? So for the long term management of diabetic mellitus type 1, you should do carbohydrate counting. So if you give 1 unit of lispro insulin to a patient, it will be able to neutralize 15 grams of carbohydrate. The second thing is you should give insulin injection via the subcutaneous route, and the site to be given is the anterior abdominal wall, which is the best site to be given insulin, and it should be given in a rotating fashion. The other sites can also be arm, anterolateral thigh, or buttocks, but the best is anterior abdominal wall. And the delivery of this insulin injection should be through an insulin pump. Continuous subcutaneous insulin infusion will be the best thing, the preferred mode, but you can also give through an insulin pen, that is a 31 gauge needle. So the needle is very thin and it is basically painless, and you can also give inhaled insulin. And but on the site, if you give the insulin through buttocks, the absorption will be impaired or lower, because the buttocks have a lot of subcutaneous fat, which may lead to less effectiveness of the insulin administered. There is also degludec and glargine. These are ultra long acting insulins, and degludec is for acts for 42 hours, and it is the longest acting insulin, and glargine is also a long acting insulin which works for 24 hours. So the insulin is given 50% as basal, and 50% of the insulin is given postprandial. Hypoglycemia is the most common complication of insulin excess, but there can also be weight gain and hypoglycemic seizures. So what is hypoglycemia? Hypoglycemia is when the blood sugar falls below 54 milligram percent, and the symptoms can be emotional lability like crankiness, diaphoresis, drowsiness, stupor, seizures, and rage attacks. So the beta blockers are contraindicated in hypoglycemia because they are symptomatic, and they are blockers of the sympathetic waves from the brain, and they will mask the symptoms of hypoglycemia and diabetes mellitus. Hypoglycemic seizures. So hypoglycemic for hypoglycemic seizures, you should give IV dextrose 25 to 50% dextrose, and if IV access is not possible, inject glucagon subcutaneously. So there are two effects we should study about, that is the Somogyi effect and the Dawn phenomenon. So Somogyi effect is due to excess insulin. So if exogenous insulin is given, the patient will develop hypoglycemia later, which makes the body release counter regulatory hormones such as glucagon and cortisol, which will contribute to breakdown of glycogen, which will lead to increase in blood sugar levels the next morning. So in this schematic representation I have made, you can see the patient is given insulin at 10 p.m. before food. His sugar was 150 at 10 p.m., but due to exogenous insulin excess, his sugar at 4 a.m. in the morning has gone down to 40 milligram percent, and it is called early morning hypoglycemia. But now, because of the hypoglycemia, the body will be producing counter regulatory hormones to break down the sugar. So in the morning at 7 a.m. his blood glucose will climb to 200 milligram percent, and this is called pre-breakfast hyperglycemia, and this is the Somogui phenomenon. So the treatment for this should be adjustment of the night dose of the patient, night dose of the insulin for the patient. In now the in dawn phenomenon, there's type 2 diabetes mellitus, the GLUT4 receptors are down regulate between 4 a.m. to 7 a.m. So in dawn phenomenon, the blood sugar values will keep on rising, so there will be a early morning hyperglycemia and also pre-breakfast hyperglycemia. So in the Somogui phenomenon, it was due to excess exogenous insulin, but in dawn phenomenon, it is due to the down regulations of the GLUT4 receptors, which will lead to early morning hypoglycemia and pre-breakfast hypoglycemia. Meanwhile, in Somogui, there was early morning hypoglycemia and pre-breakfast hyperglycemia. And this is just a small tidbit. So for insulinoma, the investigation of choice will be 72-hour prolonged fasting test. So this was my notes for diabetes mellitus part 1. I know I have made a lot of not a lot, but sometimes I made mistake, so I'm sorry for that, but this is just for private viewing, and if anyone else finds it helpful in their preparation, I'll be grateful. So if anyone is watching, thank you for watching it.